Hi, this is Brian Kim. I want to share with you this case of a patient who has a single piece acrylic yellow lens in the ciliary sulcus causing glaucoma. So this is a patient, and I've been following her. I inherited her somehow, and I've been following her. She was doing fine, and I noticed that she had quite a bit of PCO in this eye and not the other eye. And so I was like, this is kind of weird. She has like trace PCO in the one eye, and then the other eye, this one has like 4+, and it's really aggressive. And so at first I was like, okay, I'll just do a YAG, no big deal. And when I actually brought her in for the YAG evaluation, I was like, oh. And I realized it's because this eye has a single piece of acrylic yellow lens in the ciliary sulcus. And really when I look closely, it's actually tilted a little bit. And interestingly enough, this patient also has glaucoma in this eye and not the other eye with a very small visual field defect. So, the first question is, why would a surgeon put a single piece of acrylic lens in the sulcus? And I think this is somewhat debatable. I think some surgeons actually believe it's okay to keep it in the sulcus. And, short term, there probably won't be any problems, right? Patients can have good vision. In fact, this lady had very good vision and good pressure. But the problem is over time, things can change. And obviously, she has a visual field defect. There might be some pressure spikes in between. Who knows? And I don't believe it's really a stable situation. The only other thing I can think of is in some surgery centers, they may only carry a single piece of acrylic lens. Maybe they have a backup IOL, but they might not have a 3-piece lens option. And so if you're in a surgery center and there's no 3-piece option, I think this is a really big problem. And every eye surgery center should have not just a single piece of acrylic lens on consignment, but also a 3-piece lens option in cases like this. So I'm using the cotton tip and I'm just turning the eye around and I'm just trying to really get a good look and see, is this really in the sulcus? Again, I'm pretty sure it is, but I'm just kind of holding the eye looking around. I make my incision first on the right side and then the left side, making sure I'm parallel to iris plane. And I'm pretty convinced. You can see the anterior capsule is fused to the posterior capsule when you look really closely there. Pushing some intracameral epinephrine. And then some dispersive viscoelastic. So again, I go back to what I said, the bag is okay. And this is the 3mm diamond blade. And I like to use a 3mm incision when I'm doing lens exchanges because I like that bigger incision so that I can pull out those lens pieces. And it's not a bad thing anyways, because I'm also going to be using the LI61AO lens, and I'm going to be using it through the 2.8mm injector. So this is a two-handed microforceps technique. And as I lift the lens up, I can clearly see, yes, the lens is in the sulcus. You can see the anterior capsule is fused to the posterior capsule. You can see there's quite a bit of PCO as well. And very carefully, but very easily, I'm able to just fold the haptic onto itself. I'm bending it and collapsing it on itself. And I'm able to pop that left side haptic into the angle. And I'm just rotated the lens using a two-handed technique, grabbing and re-grabbing so that I can position the lens in such a way that I'm ready to cut it. So once I'm grabbing it and holding it with my serrated forceps, the IOL holder, go ahead and bisect the lens completely in half with the IOL scissors. Again, very easy so far. By doing it this way, I'm able to grab the right side piece I'm able to lift the lens piece up with the forceps closed, grabbing the cut edge, and as I pull the lens out, I'm using the left side forceps to shield the cornea. But again, the way the haptic was oriented, I knew it was going to collapse on itself and therefore be an atraumatic lens removal. Turning the left side piece 180 degrees around, and then grabbing the cut edge, again in the same manner, grabbing the cut edge, pulling it, and as I do this, the haptic collapses on itself. But again, I'm using the left side forceps to shield the corneal endothelium to make sure that the lens doesn't scrape against the cornea. So now the lens pieces are out. That didn't take very long at all. And clearly the lens was in the sulcus. Again, I'm not surprised. Why was this lens in the sulcus? You know, you have a nice rhexis. You see that the anterior capsule is completely fused on the posterior capsule. The bag looks pretty stable. And the only thing I can think of, honestly, is the surgeon put the lens in, but thought that the lens was in the bag. So I think the surgeon put the lens in the eye, thinking it was in the bag, but unbeknownst to that person, the lens was actually in the sulcus. And that is why it's very, very important to rotate the lens, making sure it's in the bag. You see that I always, with my standard technique, I get underneath the lens and I tilt it with the INA handpiece. And when I tilt it, I'm able to irrigate and remove the viscoelastic that's trapped between the lens and the bag, but then I'm able to clearly reposit it back into the bag. And these are all necessary steps. It's a validation point and a verification point to confirm to yourself that the lens is completely in the bag. In this case, unfortunately, I think the surgeon missed those cues, thought it was in the bag, wasn't in the bag, and it was actually in the ciliary sulcus. So it's really a shame because this patient had uncomplicated cataract surgery, and there was really no reason for this patient to have a single piece of acrylic lens in the sulcus, but now it's led to this glaucoma problem. And, you know, you're always stuck as a surgeon. You're like, you know, do I have to do this surgery? This patient's doing fine, seeing fine. You know, no one's mentioned any problems. And then now you come in and start saying she's got all these issues. And then you're kind of, you know, you don't want to be a bad guy because what if you do the surgery and the patient has a serious complication? And so, you know, it really takes a lot of pre-op counseling, explaining what's going on. And so ultimately she let me do this surgery. Now I'm going with the LI61AO with the 2.8 millimeter injector. I burp some viscoelastic from the main wound, which allows it to gape. And it also creates a little bit of lubrication effect, allow me to slide the injector into the eye. I'm using a two-handed technique, pushing cohesive viscoelastic with the Provis cannula. And as I'm pushing, I'm making sure that leading haptic goes into the sulcus. Remember, that's very important. Make sure it goes into the sulcus. And as I push, I'm trying to control the eye with that Provis cannula, and the optic delivers rather smoothly. The leading haptic is still in the ciliary sulcus, and then I'm able to withdraw and then push again, and the injector pushes that trailing haptic beautifully into the ciliary sulcus. Switch to the INA handpiece, and I'm using the purple sleeve. The purple sleeve is better for this larger incision, the 3 millimeter incision. And again, I went with the 2.8 millimeter injector for this LI61AO lens. I went underneath the lens, removing all the viscoelastic from underneath the lens. You can see the lens is nice and mobile in the ciliary sulcus. I'm removing all the viscoelastic from the anterior chamber. But remember, this LI61AO lens is the only lens that's approved in the United States to be implanted in the ciliary sulcus. And it's really a beautiful lens, got rounded edges, and it has zero asphericity. So it's really a great lens for this situation. Removing all the viscoelastic from the anterior chamber, you can see the lens is perfectly stable. There is no decentration of the lens. I'm turning the lens around and the haptics around, but it's staying rock solid within the sulcus. Push BSS as I come out with the INA handpiece. I'll hydrate my incisions, and that's the end of the case. So again, this is a patient who had a single piece of acrylic lens in the ciliary sulcus. Unbeknownst to me, she also had glaucoma in this eye preferentially. She also had really dense PCO preferentially in this eye and not the other eye. And so on further inspection, I found that the lens was actually in the ciliary sulcus. Again, these are tricky because I wasn't the original surgeon. And so you always assume that was performed properly. And so you kind of just glance over that, oh, the patient has a PCO, I'll just YAG it. But then I was like, no, I'm not going to YAG it, because if I YAG it and then I try to exchange her, I might have vitreous. So I told her, wait, we're not going to do the YAG. I went ahead and discussed the IOL exchange in detail. You saw how efficiently I was able to take this lens out. Again, using a 3mm blade, I was able to efficiently grab the lens with a two-handed technique using forceps, bending the haptics inward, popping the lens into the anterior chamber, cutting the lens in half, and again, cutting it in such a way that I know that the haptic will collapse on itself as I try to pull the lens piece out of the eye, shielding the cornea with my second instrument to protect the corneal endothelium, and then placing this lens atraumatically using the 2.8mm injector into the ciliary sulcus. And this patient did very, very well and was happy with her result. So I hope this was helpful to you, and I thank you for your attention.